helps as medical references to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, you should consult your personal physician. Welcome. You are about to embark on a unique learning adventure from the Great Courses. Our courses are crafted to be entertaining journeys, both comprehensive and fascinating. They're designed to expand horizons, deepen understanding, and foster epiphanies in a broad array of subjects and university-level disciplines. The lecturers are university professors and subject matter experts carefully selected by the Great Courses and its customers for their intellectual distinction and exceptional abilities to teach. By listening for less than an hour a day, you can finish even the longest course in just weeks. Browse our catalogs or visit our website at thegreatcourses.com and imagine how much you can learn if you spent just 30 minutes a day for the next year in the company of some of the greatest minds in the world. These lectures are part of the Great Courses series. These lectures are titled Medical School for Everyone, Emergency Medicine. Your lecturer is Dr. Roy Benarroch. Dr. Benarroch is a general pediatrician, an author, and an educator. He earned his medical degree at Emory University and completed his residency through Emory's affiliated hospitals, serving as chief resident and instructor of pediatrics. He has continued his involvement on the Emory faculty as an adjunct assistant professor of pediatrics. Dr. Benarroch is board certified in general pediatrics and works in full-time pediatric practice near Atlanta, Georgia. He has published 2 books on parenting and pediatric health topics and writes a blog for parents and health professionals. His essays on pediatric health have been widely published on the internet, and he has served as a featured expert on WebMD.com. Lecture 1. Triage in Emergency Medicine.
Welcome to Medical School for Everyone, Emergency Medicine. Our shift in the emergency department is about to start. We're in the parking lot of a suburban hospital. We've got a travel mug of coffee, and we've got just a few seconds to get introduced before we head through the big glass doors into the air conditioning and the antiseptic smell of the emergency department. You're just about ready. I'm Dr. Roy Benarroch, and I'll be your physician mentor for this course. You are now a medical student rotating through the emergency medicine part of your education. You'll be shadowing me on my shifts, and I'll try to teach and explain as things happen. But of course, my main job is to be the emergency physician. And sometimes there's not a whole lot of time for talking and explaining. Things may happen quickly. We'll be spending a lot of time together in the ED, that's the emergency department, and sometime out of the ED as well. You never know where or when a medical emergency could occur, so stay on your toes. Now, I'm not your physician, and I can't give you personal medical advice. That's what your own doctor is for. Unless you pursue a formal medical education, this course alone is not going to turn you into a qualified emergency physician. But by listening to these lectures, you will learn a lot about medicine and how physicians deal with medical emergencies. You'll be better prepared to help family, friends, and yourself when medical problems occur, and you'll learn how to communicate more effectively with your own doctors, especially in emergency situations. Understanding what doctors do, how and why they do it, and what it feels like to be an emergency physician, that will make you a better patient. Okay, enough talk. Emergency medicine is about doing things and seeing patients and making decisions, not about talking in a parking lot. We'll make our way in to start our shift through a side entrance. It's considered bad luck to just walk through the waiting room. Our first step is to take report. That's talking with the emergency physician who's ending her shift to see what patients are in the middle of their evaluations. We've got an easy start, it turns out. Only one patient, a boy who fell off a skateboard, and he's just waiting to get an x-ray. No worries there. There's also a boarder, a patient kind of holed up in the ED waiting for a transfer. We know her. It's a woman we actually met on our last shift, a woman named Lucy, who has schizophrenia and who had been brought in by the police. She was wandering in the street, mumbling, and didn't seem safe. She's now calm. She doesn't really say much, and she's in the back in a room waiting to be transferred to a psychiatric hospital. So that's it, the sign out, a skater boy and Lucy. We're now the physicians on duty, and we're responsible for these two patients, plus, of course, anyone else that's brought back in during our shift. Let's peer out through the glass partition in the waiting room. There's a man, maybe 50 or so, kind of fidgeting in his chair. There's a worried-looking woman sitting next to him. Maybe that's his wife. She's wearing something completely inappropriate for the ED waiting room, kind of an evening dress. So you're thinking these two just rushed in. He looks kind of sweaty and restless, and she looks worried with red, watery eyes. You wonder, which one is the patient? Further out, a few chairs down, is a more obvious case. This is another man, younger, with a huge splash of blood on the front of his shirt. He's holding a rag in front of his face, kind of over his nose, and it's soaked with blood too. There's also a young couple sitting as far as possible from the bleeding man. Between them is a baby carrier, one of those car seats that you can lift up out of a car to carry a young baby. It's entirely covered by a white blanket, but you assume that there's a baby under there, and that's probably your third patient. Got it? There's the boy in the back waiting for x-ray. Lucy, she's in the back waiting for transport. Then in the waiting room, there's that restless man or his wife, a guy who's bleeding, and a baby, presumably, hidden under a blanket. Who do you see first, and how do you get started? The first step of ED care is triage, from the French word for sorting or separating out. EDs are not like the post office or a bank, and they're not like a regular medical office. It is not first come, first served. Patients are evaluated and treated in order of risk or in order of the seriousness of their wounds or illnesses. Triage is actually both a noun and a verb. A noun as in that patient is in triage, the area where someone does an initial assessment and assigns a score or priority. Triage is also, in medical usage, a verb, as in, I'm going to triage that patient. It's an action word, and that's an important concept. I said that the first step of ED care is triage, but in an important way, that's not actually true. Triage, when used as a verb, isn't just one step you do and then move on. In an ED, triage is an ongoing process. The patient who went through triage as a low-priority patient may end up having to jump ahead of the line if circumstances change. And new patients can show up at any time with their own needs. And they can jump into the line anywhere, not just at the bottom, depending on what they need. People ask all the time, what's the best way to get through an ED without waiting? Unfortunately, the only way to do that is to be the sickest, scariest, about to diest patient in the department, and to make sure no one sicker shows up while you're being evaluated. Though no one likes to wait, it beats the alternative. In an ED, you do not want to be the person that's rushed back immediately. Okay, you've washed your hands, you've put all your street clothes in a locker, you've got on your white coat, your stethoscope is warmed and ready. The tablet computer you carry flashes the first room to head into. The staff keeps the census organized so you know what patient is in which room and who needs to be seen next, and you head in to see the man who had blood all over his shirt. He's now in a hospital gown, and someone has given him a clean towel to hold, and you can see that there's still fresh blood. He tilts his head back and says he's glad to see you, he's got this nosebleed, and it just won't stop. This is Benjamin. He's 40 years old, and before you get 2 words in, there's a knock at the door. A nurse pokes her head into the room and motions you back out. You head into the hallway, and she says, that guy in the waiting room, he's back in trauma now. He's got a STEMI. She hands you a clipboard with an EKG tracing on it, and you both start walking to what's traditionally called the trauma or resus or code room. You call over your shoulder, Benjamin, sorry, I'll be back soon. That's triage for you. Benjamin was your first patient, but he's not anymore. A STEMI is one of many quick abbreviations that ED people love. It means an ST elevation MI, also known as a myocardial infarction or heart attack. Heart attacks, I will tell you, pretty much always jump to the top of a triage list. At triage, any patient suspected of having symptoms caused by myocardial ischemia, that's insufficient oxygen to the muscle of the heart, gets an immediate EKG, ideally within 10 minutes of presentation. Symptoms like chest pain, sweating, vomiting, neck pain, arm pain, shortness of breath, dizziness, fainting, or any combination of these, especially in a person with risk factors for heart disease, they're going to get that quick EKG. In this case, the EKG shows that there's been prolonged serious ischemia to the heart muscle, leading to the death of heart muscle cells. The tracings show that a section of the line called the ST segment is elevated. That's an ST elevation MI or a STEMI. It's usually caused by a total occlusion of one of the blood vessels around the heart, the arteries that bring oxygenated blood to the heart muscle itself. Not everyone who's had an MI has these obvious changes on the first EKG. To thoroughly evaluate suspicious symptoms, you have to repeat the EKG and do blood tests. But in this case, we've already got the diagnosis based on that quick EKG from triage. Okay, you're passing through the hall into what's called the trauma room. Most EDs have one of these. It's a bigger room, very close to the front doors, where ambulances bring in patients with a central table many people can crowd around. There's bright lights, lots of instruments and things, many in open view, so you can grab what you need. There's your patient. He's sitting there with an oxygen mask over his face, and we don't know his name yet. One nurse is hooking up leads to his chest, another is starting an IV, and another one is leading his wife, well, you think it's his wife, out into the hallway. She's sobbing, but she's getting in the way. You'll need to talk to her, but now isn't the time. You offer to shake hands with your patient. He says he's John. He says sorry about the fuss. He looks sweaty and pale and embarrassed. He says he was working late and his wife was at one of those charity things, and she called him, and he doesn't even know why she drove to his office and brought him in, and you kind of wave your hand in front of his face. John, you say, we'll talk more about that later. How are you feeling? You listen to more of his story, even while the monitors pop on, showing vital signs and a heart tracing. He says he just feels really bad. He can't explain it. He thinks it's indigestion, but he feels really sweaty, and both of his arms feel really heavy. You ask him, does your chest hurt? And he says, well, yeah. He kind of pats his closed fist over the center of his chest. From the other side of the bed, a nurse hands him a pill and says, chew and swallow. It's an aspirin. You've seen the vital signs. They look okay. Normal heart rate and blood pressure, and the pulse ox measuring his blood oxygenation is fine. You ask the nurse to give him some morphine through the IV for pain and look over the EKG you've been holding. It's pretty clear there. The tracings tell the story. He's having a heart attack right now. John, you say, we have an excellent cardiologist and we're going to do everything we can to help you. You initial a brief form, a pre-written order set for this situation, so your staff, your nurses, your techs, everyone knows exactly what to do. There are labs to draw, medications to be given, the cath lab has to be called to prep, the cardiologist on call, the ICU, all of them need to be notified. There's a whole cascade of people who now have jobs to do. It's like a very complicated show or a set piece. The curtain is about to go up and everyone needs to be in place. You step into the hallway. There's John's wife. She's sniffling. Her eyes are red and puffy. I knew it, she says. He's having a heart attack. He is such an idiot. Is he having a heart attack or what? You say, John's safe. He's stable and comfortable, and we're getting a lot of things in place to help him. Yes, he's having a heart attack. Does he have a cardiologist? No, he doesn't. But he smokes and he works too hard, and I just had this feeling, and I called him, and he sounded weird. He sounded out of breath. He said his chest didn't hurt, but I didn't believe him. That's true, you think to yourself. When you spoke to him, he didn't even mention the chest pain. You had to ask him. That's not uncommon. People having heart attacks or other serious health problems can sometimes be very good at ignoring or denying their symptoms. It's also true that not everyone having a heart attack even has chest pain. But his sweatiness, his shortness of breath, that heavy feeling in his arms, especially in a smoker, all of this fits an MI. You talk with John's wife about other medical issues that you need to know about. He hasn't been on any medication, hasn't had any heart problems or any previous chest pain or episodes like this. He really has no other known medical problems, no high blood pressure, no diabetes, nothing. You make sure that there are no medical issues that could complicate the treatment plan, which is to get him to the cath lab to open up his clogged artery as soon as possible. Certainly within 90 minutes, or better yet, within an hour or less. The goal of treatment for a myocardial infarction is to rapidly open up the blocked coronary artery to reestablish blood flow as quickly as possible. That won't revive dead cells, but it will prevent more heart cells from dying. There are two ways to do this: clot-busting medications, or what's now called percutaneous coronary intervention, or PCI. That's going into the femoral artery in the groin and snaking up a catheter up into the chest and into the coronary arteries. Then you can squirt in dye to find the blockage and use balloons, stents, and other methods to open it up. If PCI is available within 90 minutes, that's usually the best approach for a STEMI. After you leave John and his wife, they're holding hands now. She doesn't look as mad as she had in the hallway. You glance at your tablet and see that an X-ray result is ready. That's from the skater boy that was signed out. And you recall that you had walked out on Benjamin with his bloody nose. And the baby from the waiting room is now back in an exam room with a notation that the concern there is congestion. A few quick touches, tap, 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 you're looking at the boy's X-ray. It looks fine. And the radiologist has read it, and it's normal other than some swelling. You figure that will be a quick one to finish to get that family out of the ED. But on your way to meet him, you figure you'd better stop in and see Benjamin with a nosebleed. His room is a mess. There are about 6 bloody towels on the floor and more in the trash can. He's still sitting up on the table with his head tilted back. His hospital gown is bloody, and he does not look happy. It won't stop bleeding, Doc. You review the history. He says this has never happened before, and that he's not sure when it started bleeding, sometime earlier today, he guesses. You don't learn much more from the history, and the physical exam only reveals a bleeding nose. You tap in orders, asking your staff to draw labs, to check his clotting system and blood counts, and to keep a tube aside for testing in case a transfusion is needed. Most nosebleeds, even really bad ones, don't lead to enough blood loss to need a transfusion, but it's better to be safe. If you're asking a phlebotomist to draw labs, it's better to get them all at once. You also ask the staff to repeat his vital signs, hook him up to monitors, and leave an IV in his arm. They'll also administer a nose spray to constrict his blood vessels and help him hold pressure on his nose. And get him a new gown, too. Okay, while that's all taking place, you go see the patient you've been thinking of as the skater boy, since you hadn't met him yet and can't remember his name. By the way, are you getting the impression that working the ED sometimes feels like spinning a whole bunch of plates in the air at once? That's exactly what it's like. And this is really not a busy shift, at least not yet. Skater boy, it turns out, is Malcolm. He's 10, and he's cradling his elbow. You shake the opposite hand, and someone, an older man, maybe his grandpa, says, "Is it broken, Doc?" You introduce yourself to him. By the way, you always introduce yourself to everyone in the room. You've learned never to assume who people are, and that a quick handshake and acknowledgement is a good way to help people feel at ease. "I'm sorry for the wait," you say. "There's a lot going on today." As usual, no details. ED staff should never say what's going on in the other rooms with other patients. It's unprofessional, and people deserve their privacy. "I'm his grandfather," the man says, "and his arm's hurting real bad. Is it broken?" "I don't think so," you say. "The X-ray looks fine." The man looks over at Malcolm. You see, it's not so bad. The boy just kind of glares back, then looks down. It hurts, he says. You look over the intake sheet and the notes from the doc who did his evaluation during the last shift. 10-year-old boy fell from skateboard 8 days ago. Vitals look okay, though he's got just a little minor fever. Temperature is 100.8. Why'd you come in today, you ask? It hurts bad, says Malcolm. He looks at you, frankly, like you're an idiot. He's been complaining more and more, says Grandpa. It's hurting more, you ask? Malcolm gives you a look that says, can we get another doctor? There's some kind of commotion outside. You hear kind of a yell. You look at Malcolm and say, you fell last week, but it's hurting more now? Is it hurting more than yesterday? Malcolm nods. He says, yeah, it hurts real bad. Now, knock, knock, knock goes the door. Your nurse says you'd better get out here. You apologize and you head out and you walk straight towards the trauma room. Automatically, without thinking about it, you know that's where the problem is likely to be. On the way there, with the nurse by your side, you say, get that boy an IV, get a CBC and a sed rate, and a blood culture. She taps those orders into her pad as you walk into trauma. By the way, you walk, you don't run. Running just knocks things over and gets people out of breath. And people run over each other, and it's not good. You walk into the trauma room, and John is now in cardiac arrest. His wife looks stricken and wide-eyed. John is sort of gasping and white, and glancing at the monitor next to his bed, you can see his heart is beating way too fast. This is what's called a tachyarrhythmia, a heartbeat that's abnormal and much, much too fast to actually circulate any blood. There's no circulation and no blood getting to the brain or anywhere else it's needed. Someone is leading John's wife out again. Someone else has picked up a clipboard and is standing off to the side, writing things down with their time as they occur. Someone else is across the table with both of his hands on John's chest, pushing down and up hard and fast. The nurse who walked with you back to the trauma room has picked up a phone to alert the cath lab, even while she's opening up a drawer to prepare emergency medications. Triage, again. Benjamin, the nosebleed, had made it to the top. You did an initial evaluation and then moved back to Malcolm, the skater boy. But John here just jumped to the top of the list again. And this cannot wait. You call out orders for medications to run in through his IV. A big, thick sticker pad has just been applied over his chest, and it's now plugged into the defibrillator that's been rolled in from just a few steps away. On television, they use those big metal paddles, but in the real world, a big pad with sticky goo on one side is a much better way to transmit electricity. You glance at the rhythm on the monitors one more time. You call out clear, loud enough to be heard over the hubbub. But remember, no running and no yelling either unless you really have to. You've got a good, calm team. No one is making a lot of noise. People are just quietly doing their jobs. There's a pause as people take a step back. The chest compressions are stopped just for a moment. John has stopped gasping. He's pale and he's not moving. You reach over and push the shock button. John tenses up. For just a moment, just a single jerk as his muscles contract. The person who had been doing chest compressions has his hands on John's chest again to restart if needed. The wide up and down lines in the monitor just stop. There's a straight line for a moment or two. Then the heart starts beating again in a normal rhythm. There's a quiet beep, beep, beep from the monitor. You feel John's pulse yourself, just to be sure it's there, strong enough, and you wave off the compressions. You call out instructions for medications to prepare for intubation. That's a crucial emergency procedure, putting a plastic tube down the throat into the trachea to allow a machine to do the breathing for a patient. John's going to need that for the catheterization anyway, and he's had one arrest and is at risk for more. We need to ensure that he's well oxygenated to protect his heart and brain. Usually that would be your job now, but the cath lab is ready for him and they'll take over. The cardiologist and anesthesiologist are just now entering the trauma room, and they offer to take it from here. Thanks, you say. And the anesthesiologist is opening John's mouth to see what the airway looks like. You have a few words with John's wife, who looks scared to death, but you know you've got other patients to see. To catch up a second, though, what happened to John? We know he had had a heart attack or an MI with an area of heart muscle damaged by lack of oxygen. The heart tissue is mostly there to squeeze blood, but there are also stripes of tissue within the heart to carry electrical signals. These ordinarily trigger organized contractions of the muscle, rhythmically, to squeeze blood out. When the heart tissue is damaged, those electrical circuits can be damaged too, and instead of organized beating, you can get electrical impulses that essentially run around in a circle, triggering very fast contractions that can't effectively pump blood. If this continues, the patient will be dead in minutes. Defibrillation, the shock of electricity we administered, depolarizes or resets all of the heart cells all at once, stopping that repetitive abnormal rhythm. Shortly after defibrillation, the pacemaker cells of the heart can resume their rhythm, so the heart can once again pump blood effectively. It's like resetting a computer or turning a computer off and then on again. You stop what's happening and you start over. You head back to Benjamin, who stopped bleeding and apparently wants to leave. You look over his labs and vitals, they look fine. You finally have a chance to talk with him. How often do you get these nosebleeds, you ask? He says, all the time. It's the cocaine, and he knows he has to stop, and he will, and can he just go now? You do a brief physical exam. Benjamin looks fine. There's no other bleeding or bruising, and his nose is filled with dried blood. You write an order to give Benjamin a referral to a substance abuse clinic, and you head back to the skater boy, Malcolm, who looks even less happy to see you, now with his IV and having had blood drawn for labs. The results aren't back yet, but you explain that you're worried something else is going on here. You suspect this isn't just a fracture for two reasons. The X-ray was normal, and even if there was a fracture, the pain shouldn't be getting worse a week after an injury. You'll be back once you see the lab results. Meanwhile, you go see the baby, who turns out to be Molly, 8 months old. She's had cold symptoms, a cough and running nose for 5 days and no fever, and she's been feeding well. But last night, she was up screaming a lot. She looks good, healthy and pink, though like Malcolm, she doesn't look happy to see you either. Vital signs are normal, and the exam shows normal lungs with clear and easy breathing. Her heart exam's normal, her nose is crusty and stuffy, and both of her ears are infected. Quick instructions, ibuprofen for discomfort, an antibiotic prescription. See your pediatrician next week to recheck the ears, and Molly's ready to go. Out the door. A brief recap now. John's gone to the cath lab. The trauma room is being cleaned. Benjamin with the nosebleed is gone. Molly the baby is done. Lucy the boarder has been quiet, and Malcolm's lab results have now popped up on your screen. His white count and SED rate, that's a measure of inflammation, are elevated. He had had a fever, remember, too. Plus that unusual story of elbow pain getting worse and worse 8 days after a fall. What's going on with Malcolm? We strongly suspect osteomyelitis, an infection of the bone. Often, osteo starts after minor trauma, or maybe that fall was just a red herring. You knew the story and X-ray didn't fit, and that's why you looked further. Malcolm doesn't need a cast for a broken elbow. He needs IV antibiotics and an orthopedic surgery consult and pain medication. He'll be admitted to the pediatric service upstairs. You'll need to head back to Malcolm and Grandpa to explain the plan, but mentally you think, Malcolm, done. So what do you think? A good first day in the ED? We'll go visit Lucy next, plus whatever else shows up through triage. In other words, we'll keep the plates spinning. Anything and everything comes through the ED, and anything and everything goes through you, the emergency physician. Triage, then treat, then repeat. We'll see you next time.
Lecture 2. Emergency medicine means thinking fast.
Welcome back to Medical School for Everyone, Emergency Medicine. I hope you've been able to catch up on some sleep since our last ED shift. Today, we're going to spend some time out of the hospital, on the scene, along with an ambulance crew. Now, this is not a traditional part of medical school training, but I think it's an essential part of understanding emergency care. The question, what's the first thing to do, is sometimes the most difficult step for people to get past when faced with a medical emergency. Today, you're in the shoes of the men and women who are the first responders. Sitting with the ambulance crew, one thing you'll realize quickly is that there's some downtime between cases, time to think and read, maybe catch up on paperwork. There's a little time now to catch up on the background of EMS training. EMS stands for Emergency Medical Services, an umbrella term referring to the people and the resources who provide emergency medical care and transport for sick or injured patients. The system was originally run by funeral homes. In the past, anyone who really needed emergency care was likely to die anyway. And in those days, there really wasn't any attempt to provide care at all. Modern EMS care is now a crucial part of the healthcare system, delivering high-tech, life-saving care at the scene. The training of EMS personnel is through specific programs. This isn't part of the nursing or physician professions, but a different training system that has a different set of priorities. Though nurses and doctors can and do assist at emergency scenes, it's the EMS-trained people who really know what to do. One of the most useful things for a physician to do at the scene of a serious accident is to call for help and get out of the way when the ambulance arrives. To cover some of the lingo, there are several levels of EMS personnel who work an ambulance crew. The most basic training is done by an EMR, or Emergency Medical Responder. Above that are EMTs, that's Emergency Medical Technicians, or advanced EMTs, who can handle more complex situations. The best trained person on a crew is the one called a paramedic, or sometimes just a medic, who can perform the most complex and life-saving procedures. Okay, a call has come in. There's an automobile accident, one injured passenger, time to head out. More lingo, the ambulance itself is probably called a unit or a rig or a truck, though I think there's quite a bit of regional variation here. I've been told in New York it's called a bus. Whatever you call it, hop on and buckle up. On the way to the scene, let's think about a principle of emergency care. You have to think fast and act fast. The initial steps of emergency care are actually quite simple and straightforward. What to assess, what to do, and EMS responders and ED personnel will often have to think quickly before they even have all of the information. A scene response is not the time or a place for complicated care plans. Think fast means keep it simple, deal with life threats, and figure out the details later on. A quick ride, and we're on the scene. The rig is parked to block oncoming traffic. That prevents a second crash and helps protect the crew and the patients. We arrive at about the same time as a fire truck dispatched to help out. Step 1, size up the scene. The first priority in any emergency is always the safety of the crew. In this case, there's a minivan with its front end crushed in by the side of a concrete barrier, half in the shoulder lane. One of the EMTs, before even approaching the vehicle, walks all the way around it, looking for potential dangers to the crew, like a steep incline, spilled fuel, or a fire. Crew safety always comes first because you can't help other people if you're injured or dead yourself. Crew safety also means protection from infection. These are called standard precautions to be followed whenever there's the potential exposure, blood or other bodily fluids. Gloves are worn, and if the scene is messy, the crew can quickly don eye protection or even bodysuits to prevent exposure to potentially infectious material. Next, who are the patients? Approaching the vehicle, we see the driver tangled up in a deflated airbag. Her door opens easily. That's good. You identify yourself. We're the ambulance crew. We'll help you. And then you ask the first question, is there anyone else in the vehicle? She doesn't respond, and you look around and see the back of a car safety seat strapped in. You can't tell if there's a child in there or not. Remember, dispatch said 1 injured passenger, but you can't assume that's correct. Instead, think fast. A car seat means there might be a child back there, or even a child ejected out of that car seat. Okay, we're still on the first step, scene size up. The side door of the van near the car seat won't open. But before swinging an axe through the window, you jog around to the other side and that door slides easily. There's a young child in the car seat crying. You can see through the rest of the vehicle, there's nobody else. By the way, if this were a convertible or a car with a big sunroof or a knocked out windshield, or if it looked like the vehicle had rolled over, one of the crew would carefully look around the scene for a potentially ejected passenger. So, there are 2 victims, and you know the mechanism of injury was a motor vehicle accident. One is a young child crying. That's good, actually. Crying means there's breathing and circulation. The other is an unconscious driver. We move on to the next step, called the primary assessment. We've got a big enough crew on the scene now between the ambulance and the firefighters, so one group will take care of the child while we concentrate on the driver. If there were fewer of us, the driver would get first attention because we know the child is crying and breathing. The driver, well, we don't know yet. She is potentially in much worse shape and needs attention first. The purpose of the primary assessment is to identify and treat potentially life-threatening conditions. Our patient is slumped forward across the steering wheel, and she's unresponsive. One tech climbs in the vehicle behind her to help hold her head stable and straight as you lift her upper body off the steering wheel. She's breathing, you can tell, though she's still not responding. Because the accident was high energy and her head seems to have slammed into the airbag, it's important to use what are called C-spine or cervical spine precautions. If she has a neck injury with a potential fracture, moving her head the wrong way could cause a severe spinal cord injury resulting in paralysis. The team uses a hard board behind her back and eases her head back into a firm shell to hold it in place. Then they carefully lift her out of the driver's seat onto a waiting stretcher. This is a move that's been practiced dozens of times, maybe hundreds of times, and it's done with speed and precision and confidence. Get her out, get her on her back, protecting her neck the whole time. Continuing the primary assessment, your patient is on her back on a hard board protecting her spine. She has a bloody nose and mouth, maybe a tooth has been knocked out, but she's breathing and moving her arms at least some. "Ma'am, can you hear us?" She moans and kind of points and says something that sounds like baby. She's trying to turn her head to see. You say, "Your baby is okay. We're checking him out. Just try to be still." She lets her hands fall to her sides. That's kind of a gesture of agreement. You notice some tears on her face, and her cheek looks puffy and red. The first step of the primary assessment is that general impression. Is the patient responsive? In this case, she is, and we'll move along with the next steps in a moment. But let's take a brief side trip. What would we have done with a completely unresponsive patient? The guidelines for treating an unresponsive patient call for immediately checking for cardiac arrest and beginning CPR as soon as possible. For trained medical personnel, that means briefly checking for a pulse. If there is none, chest compressions are begun to restore circulation hard and fast while an automatic external defibrillator is applied. Again, this is a good example of our lesson today. Think fast. In an unresponsive adult with no pulses, start compressions first before even thinking of other things. After chest compressions are started, another team member assesses the airway, opening the mouth and jaw so air can get into the lungs. The third step of CPR is breathing, giving rescue breaths. It's not typically done by mouth, but with a bag and mask device. Laymen are encouraged to do mouth-to-mouth breaths if no other protective equipment is available. The order of CPR: circulation, that means chest compressions, airway, then breathing, is abbreviated CAB. The CAB order improves the survival chances of an unresponsive patient better than the order that used to be taught, ABC. Remember, with a completely unresponsive adult patient, the first step is to restore circulation with chest compressions even before checking the airway and breathing. Back to our patient. She is responsive, so we don't just jump in and start chest compressions. The next step is to get a better assessment of her consciousness by asking a few questions. What's your name? Where are you? What day is it? What happened just now? These questions, asked briefly, will give you an idea of her orientation and brain functioning and provide an important baseline to later see if our patient's mental status is improving or declining. For now, our patient says her name is Judy. Then she closes her eyes and doesn't answer the other questions. We said before that in a truly unresponsive patient, the order of CPR was CAB. But there's still a place for the time-honored traditional order, ABC, and that's how we're going to now proceed with our patient. Continuing our primary assessment, we'll evaluate her airway. Is there anything obstructing airflow? She's got a chipped tooth and a little blood in her mouth. We'll use a suction device to clean that up. If her consciousness were more depressed, we'd also worry about her being unable to keep her own airway open. In a coma, the tissues of the throat and neck fall inward and close the airway. If she were at risk of that, we'd try to push the jaw forward, lifting the tongue from the back of the throat, or we'd use a plastic device in her mouth or nose to keep Judy's airway open. For now, Judy seems to be keeping her own airway open, so we'll move on to the next step, assessing her breathing. You check her respiratory rate. It's normal, and her breathing doesn't seem to be labored. Your partner puts on a small oxygen mask. Giving extra oxygen at this point won't hurt. You can move on to the next step, assessing circulation. That means checking the heart rate and pulses and taking steps to support circulation by trying to stop any significant bleeding. Judy's pulses are strong. There's some bleeding from the nose and mouth, but not too much, and her eyes are back open and she's asking about her baby again. Those are good signs. The last step of the EMS primary assessment is called a rapid scan, done after the ABCs to look for any other life threats prior to transport. This may require removing or cutting away clothes, though there should still be an effort in the field, if possible, to protect patient privacy. Is there a badly broken limb or some kind of projectile buried in the chest? The rapid scan should be quick, maybe 90 seconds, and relies on inspection, palpation with the hands, and auscultation or listening with the stethoscope. Are her breath sounds over the right and the left lungs about the same? If not, there might be bleeding in the chest or some other problem that could become very serious very soon. The rapid scan on Judy doesn't reveal any surprises. Our status at the end of the primary assessment. Judy's airway is open, she's breathing, her circulation is good, she's alert, and her neck and spine are protected from further injury. We're now ready to consider transport to the nearest trauma center. This whole process on scene has taken about 4 minutes after a 5-minute ride to get here. Not bad. For transport priority, the sickest patient needs to be transported to a hospital for definitive care as quickly as possible. Definitive here means fixing what needs to be fixed, usually in the operating room, a ruptured spleen or a severed artery or bleeding in the cranium or fractured ribs that prevent normal breathing. We're now in the so-called golden hour. In major trauma, survival rates drop if definitive operating room care isn't begun within 1 hour. There's also the so-called platinum 10 minutes for scene response. EMS should assess the patient, manage life-threatening conditions, and begin transport to a trauma center within 10 minutes. And that's where we're heading now. Judy's loaded on the ambulance. We're ready to go. After the primary assessment, there are times when a secondary assessment is appropriate, either when the patient isn't badly injured so you've got time on scene, or when transport isn't available yet, or when the clinical situation is changing rapidly. In any case, we would never delay available transport for secondary assessments or other care. The goal is quick assessment, dealing with immediately life-threatening problems, then rapid transport to a site where definitive care can begin. What about the baby? We're less worried about him. He was correctly restrained in a car seat with a harness attached at 5 points. And as recommended, up until about age 2 years, he was facing backwards. Let me explain the importance of that. The driver, of course, is facing forwards, and her vehicle suddenly stopped when it hit the barrier. Her head, though, kept moving forward into the hard steering wheel and windshield. The airbag offers some protection, but the head still snaps forward, which can cause injury to the brain and the neck. The baby in the back of the vehicle facing backwards is protected much better. When the car abruptly stops, the back of his head pushes into the car seat, but it can't move far. A backward-facing car seat, correctly installed, is the second most important safety device to protect a baby in a car accident. The only thing more important, if you want to keep a baby safe, is the driver, a sober, careful, speed limit obeying driver, not distracted by texting or a cell phone. Many accidents can be prevented or at least mitigated by drivers who are paying attention. The baby has been extracted from the car seat and is being carried by one of the EMTs. He's not crying anymore and is looking around for his mother. He's also pulling off the EMT's glasses. His vital signs have been checked. They're normal. He'll get a full assessment at the ED, which is good because it's time to go. Someone takes the car seat out of the van so the baby can ride in it on the ambulance, and mom and baby head off to the hospital. Now that the ambulance is full, we'll get a ride back to the hospital with the crew on the fire truck. Or maybe not. A new call on the radio. There's a fire of some kind in a warehouse nearby. We're heading over. While we're heading over, let me take a moment to talk about bystander response. For those of you without medical training, what should you do when you come upon a car accident? Just like a medical responder, ensure your own safety first. Thinking fast here means protecting yourself. If you can do it safely, pull your vehicle in to block the accident from further traffic. But be sure to leave space for emergency vehicles. Put on your hazard lights. Do not leave your vehicle where it's likely to get hit, and do not step out into traffic. Call 911 to activate emergency services. Don't assume someone else has already done that. Be ready to give a short description of what you see, how many vehicles are involved, an estimate of how many people are injured, and an accurate location. Unless you've got specific medical training, it's usually unwise to move any victims. You can reassure them that help is on the way. Now, there may be exceptions. If the vehicle is on fire, you'll need to decide if you can rapidly move someone without endangering yourself. Then get out of the way when the trained professionals arrive. We're here at the next scene, a fire at what looks like some kind of warehouse. Now, you're traveling as a ride-along, as a medical student, here to observe medical care. You are not going in or even near the flaming building. The fire rescue teams will cordon off the area, making sure the scene is safe. They'll be the ones checking to be sure that no toxic fumes are part of the risk from this fire. And the warehouse might be storing some kind of chemicals. We don't know yet. For now, we'll stand off to the side where it's safe while the firefighters do their jobs. Let's think ahead, though, about burns and smoke inhalation. The first steps when people are brought out of the building are those ABCs we've talked about before. Assess the airway and open it up if it's not open. Assess breathing and give rescue breaths if there is no respiratory effort. And see if there's circulation from a beating heart. If not, begin chest compressions. We're going to give supplemental oxygen to just about anyone who's been in or near a fire, too. We'll monitor vital signs, get an impression of every patient's mental status, and do a thorough secondary assessment to look for burns and begin management in the field. We'll also need some additional information to accurately predict who's at risk for smoke inhalation injury. And we need to know if there's any potential for toxicity from chemical fumes. That's a whole lot at once. But keep in mind that dealing with a fire or any emergency isn't an individual effort. Hopefully, you've got the resources in place so several people can evaluate and treat each victim at the same time. Okay, the first victim is out. A woman is walking, half supported by a firefighter. She's coughing, and she's talking and pointing to show the firefighter where other people are in the building. So we're already past the ABCs with her. She's obviously breathing, and her circulation is good enough. You ease her down into a stretcher. The firefighter tells you she was in an enclosed room with a lot of smoke, but she had been smart and was lying on the floor, crawling towards the door. Lying on the floor was the right thing to do. Smoke inhalation accounts for about 80% of deaths from fire, and hot smoke rises to the top of a room. If you're in a fire, get low where it's cooler and less smoky. Smoke inhalation is dangerous not because of the heat. Air in a fire usually cools off as it's inhaled, but because of the high concentration of carbon monoxide and carbon dioxide gases in the smoke. These saturate the blood, preventing oxygen from being carried to the tissues. There's also the potential for cyanide gas exposure from any fire that burned or melted plastic materials. So providing extra oxygen to anyone with potential smoke inhalation is a crucial first step. Later on, the ICU is going to have to deal with delayed complications from smoke inhalation, from soot down in the lungs to inflammatory changes. But for now, we'll get this first victim on a high-flow oxygen mask, take vital signs, and begin our secondary assessment. There's a metal chain she's wearing around her neck, a necklace. That comes off immediately. Metals, belt buckles, and heavy clothes can trap heat and lead to extensive delayed burns. You want to be especially careful with children or babies or people who can't talk. They won't tell you where the burns are or where they're hurting. So you have to look them over head to toe and remove whatever clothes you need to get an accurate assessment and to keep them safe. For burns, first aid begins with stopping the burning process by removing clothes and jewelry. Then, burns should be cooled by irrigating them with room temperature water. This reduces cellular damage by limiting the depth and the width of burns. Ice is not a good idea. It freezes tissue and can actually increase tissue damage. Cooling a burn with ice is more harmful than using tap water, and it's even more harmful than doing nothing at all. So tap water, that's the way to go. Just splash it across and over the burn, lots of water, not under pressure, just gentle splashes to reduce the temperature of the burn. That's the best first aid for home use, too. Okay, your patient is lying down, she's on oxygen, her clothes are off, she's under a sheet for privacy, and a large burn on her thigh and leg is being irrigated with water from the fire truck. Her vital signs are okay. We can take a moment to look around to see if any other teams need our help. It looks like 4 more victims have been removed from the building, and the firefighters say that's everyone. They're concentrating now on controlling the fire. The on-scene paramedic, the most highly trained senior on-site EMS person, is talking into a radio to get dispatch instructions. More ambulances have pulled up, there's plenty of hands on scene, and it's time to arrange transport. The paramedic asks you about your patient's status. This is your quick summary, just the facts. Vitals normal, she's ambulatory and talking. Her voice is hoarse and she's coughing. She was in an enclosed room with smoke. One large 2nd to 3rd degree burn on her leg, estimate 6% BSA. The paramedic nods, good job. And she says, okay, get her on rig 1 there, ride on and get access if you can. Let's go through that quick summary, what you kind of reeled off to the paramedic quickly. These were the most essential things she needed to know. You started with vital signs normal. That reflects those crucial ABCs. Then the phrase, she's ambulatory and talking. That's to describe her overall functioning and mental status. Ambulatory and talking is much more reassuring than comatose or unable to speak. You also mentioned that she's hoarse and coughing. That was to express the findings that make you worry about potential smoke inhalation, along with what the firefighter had said. She was in an enclosed room with smoke. That put her at risk. You also mentioned the large burn and the location. That's important because burns on the neck or chest or face, especially burns near the mouth, can lead to additional complications from problems with breathing and circulation. Then you said an estimate of the burn size, saying 6% BSA or 6% body surface area. That estimate is based on what's called the rule of nines, a shorthand way of estimating burn size. It breaks an adult's body up into zones, each of which has a multiple of 9 to add up. The head, front and back, is 9%, each arm is 9%, each leg is 18%, and the entire torso is 36%. This system doesn't work as well for children, but it's easy to remember and a reasonable first guess for the field. Our patient had a large burn of the lower extremity on her thigh and leg. The whole lower extremity would be 18%, and we figured her burn covered about a third of that for an estimated burn size of 6% of her total body surface area. An accurate burn size estimate is important. Larger burns are much more likely to lead to big inflammatory changes requiring advanced support, and larger burns will require more aggressive fluid management. Burns always lead to a loss of fluids, both directly from the exposed burn, but also from fluid seeping out of the circulation into the tissues around the burn. So an accurate estimate of burn size helps with triage, who needs what level of care the fastest, and with starting appropriate fluid management. We'll ride along with our patient to the ED. On the way, as the paramedic instructed, we'll help try to get access, referring to IV access, an intravenous line for fluids and medication. We're going to need that for pain control too. This burn is going to start to hurt soon, and we'd better be able to give her something for comfort. Think fast means use your time wisely. While riding in the ambulance to the ED, if you've got some time to get it done, starting an IV line can be a big help. Let's recap. Our priorities. First, personal and crew safety. Secure the scene. Then, ABCs. Address the immediate life threats. Then deal with fixable things while arranging transport. Never delay transport to address something that isn't life-threatening. In a trauma situation, don't forget to protect the spine. Give extra oxygen, especially if there's been smoke inhalation. With a burn, cool the area with tap water. And don't forget, patient safety, privacy, and comfort are all important too. Thinking fast is an essential skill for first responders and for EM doctors and nurses as well. But sometimes things can get more complicated than they first appear. Thinking fast is a start, but sometimes good emergency care requires you to think fast and then think again. See you next time.
Lecture 3. Emergency medicine means thinking again.
Welcome back to Medical School for Everyone, Emergency Medicine. Today, we're back in the emergency department, a night shift this time, where anything can happen. In our first 2 sessions together, we've already learned some good lessons. First, emergency medicine is triage. You triage a group of patients, treating the sickest or most at risk to die first. But you also triage each individual patient, too. Patients always have a list of problems, both their own complaints and physical findings you uncover. Maybe Mr. Johnson has a cough and a fever, and you also notice he's breathing fast. And you also notice a rash and that he's overweight. Which of these problems do you address first? That's a kind of triage, too, and it's essential for efficient and effective emergency care. We've also seen how important it is to think fast. In emergency medicine, you assess and then you intervene. But that's not to say that emergency medicine is knee-jerk medicine. Some of the smartest, best-thinking doctors I know practice emergency medicine. In the ED, you do have to think fast, not just once, but again and again as circumstances change. It's think fast and then think again. Okay, we're ready to sign into our shift. 2 patients are in the ED. The first is an elderly patient brought in from a nursing home because he's become less responsive. You're told that on presentation here, his temperature was a little low, but his color and other vitals were okay, and he's waiting for labs to come back. The other patient is a college student, vomiting, now on IV fluids. The sign out is a little rushed because just as you came in, a call came over the radio that an EMS crew is bringing in a possible MI, that's a myocardial infarction or heart attack, a man with chest pain and shortness of breath. The doc who just signed out, she says, you go meet him, the chest pain. I'll make sure those other 2 are tucked in before I split. In ED language, tucked in means essentially that a patient is getting the care they need for the time being so they can be safely ignored for at least a little while. That's the magic of triage. Our possible heart attack is being brought back. He's a youngish-looking man breathing loud. He's agitated, and he's pounding on his own chest saying, I'm having a heart attack. I mean, he literally says that with his voice in between breaths. I am having a heart attack. The ambulance crew tells you this is Simon. He's 36 years old. He called EMS from a party. He's reporting shortness of breath and chest pain. And on the ride over, he started saying his face and his arms had gone numb. Your techs and nurses have moved him into a trauma bay, and an EKG is being done. Simon is already getting extra oxygen through a mask, and your team is getting ready to draw some blood. Simon's first set of vitals includes respiratory rate 40, pulse 110, blood pressure 130/80, and a normal pulse ox. So what do you think? Just first impressions. Simon might be having a heart attack. He does have chest pain and shortness of breath, but he seems really almost too agitated. And what's this about his arms and face going numb? You can get arm pain or less frequently tingling during a heart attack, and maybe even jaw pain, though both arms and face going numb here doesn't quite fit. And he really is breathing very, very fast, like he's in a panic. You tell the team to proceed with what they need to do to evaluate Simon for a possible MI. Think fast means treat the most significant possible life threats first, even while you think again. In this case, thinking again about what really seems to fit this presentation well, which is a panic attack with hyperventilation. You tell Simon he's okay, he is not going to die, and you're going to take care of him. Just breathe slow. You talk low and steady, trying not to make things worse. In truth, it's unlikely that you can talk someone down from a full-blown panic attack. A panic attack is not going to kill Simon, but if Simon is having one, he thinks he is going to die. A panic attack is a remarkably frightening experience. It is very real and can cause chest pain and a feeling of an inability to breathe, even while someone is actually breathing very well and very quickly. Too quickly, in fact. Many people during a panic attack hyperventilate, breathing so quickly that they blow off too much carbon dioxide or CO2, leading to a temporary rise in blood pH. This causes uncomfortable muscle spasms and a tingling sensation in the hands and feet and often around the mouth. Remember, Simon, he said his arms and his face were numb. In this case, that's probably from hyperventilation. One first aid treatment for hyperventilation is to have the person breathe in and out of a paper bag. The idea here is that the patient rebreathes his own CO2, so the blood CO2 doesn't fall as much. This kind of treatment isn't ideal, though, because the patient will also be rebreathing air that's become low in oxygen. In the ED, with Simon, paper bag rebreathing isn't done because it's still possible that Simon is, in fact, having a heart attack. Or he might even be having both at the same time, a heart attack and a panic attack with hyperventilation. Of those, what will kill him is the heart attack caused by low oxygen to the heart muscle. So paper bag rebreathing, even if it helps the symptoms of hyperventilation, may lower available oxygen, making his possible heart attack worse. For first aid at home, for someone who's known to be prone to panic attacks, briefly breathing in and out of a paper bag for a minute or two is probably harmless and might help. But don't leave the bag on for very long. Never make a really tight seal with it, and never use a plastic bag that might fully prevent oxygen exchange. What's most important during a panic attack is quiet reassurance and not panicking yourself. Keep cool, and the panic attack will pass. There are also medications that can be given for panic and anxiety, though they're more typically used for long-term relief for people with recurrent panic attacks. While the nurse stays close to the patient, you look over the EKG. It's normal, other than a fast heart rate. Simon's vitals are otherwise okay. His breathing is slowing, and his color is improving. You ask him about his medical history, his heart attack risk factors, medication history, has he taken any other drugs, and has he had panic attacks before? And he shakes his head no to everything. You'll check in on him again later. Let's head down the hall. Our next stop is Nicole, the college student. Remember, the sign out said she was brought in for vomiting. She's now stopped vomiting and is hooked up to an IV, and she looks reasonably comfortable. How are you feeling? You ask. She just looks away. You introduce yourself. You shake her kind of limp, reluctant hand. You say again, how are you feeling? She says, okay. Nicole's story, reviewing the computer entry from the doc on the last shift, she's a 20-year-old college student brought in by her roommate. She had been vomiting for about an hour, and the roommate got scared and brought her in. The roommate has since left. There's been no fever, no diarrhea, really nothing other than the vomiting. You see on the sheet that there are no drug allergies and that the only medicine Nicole takes is Zoloft, a medication used to treat depression and anxiety. Nicole had brought the empty bottle with her and shown it to a nurse. At presentation, Nicole had been sleepy and a little, as we say, a little out of it. This was thought to be from dehydration, from the vomiting. Vitals were normal. She was given medication to ease the vomiting and started on IV fluids. Labs were sent off, and those are back now, and they're normal. Now it's time to think again. Why was Nicole vomiting? Does this story fit together the way it should? The most typical reason for vomiting is the so-called tummy bug, usually a viral infection that's more properly called gastroenteritis. This is very common at any age, and of course, most of us have had this, maybe even more than once. It starts with nausea and then vomiting, often followed by diarrhea. There's sometimes a fever, and sometimes there'll be an achy kind of feeling, just that virus yuck feeling we've all had. Nicole, though, of all of these symptoms, all we've heard about is vomiting. No diarrhea, no fever. Think again. Can we shut the door here? Are we satisfied that this is just a tummy bug? Let's think about other causes of vomiting. I know maybe this is not something you planned to think about today, but this is medical school for everyone. And in medical school, we get to think about all kinds of things. In medicine, we call a list of possible diagnoses a differential diagnosis, or sometimes just a differential. The differential diagnosis for vomiting, a list of all possible causes, is huge. And we don't need a super detailed list here. This is an ED. We need to think fast. But we do need to at least consider broad categories of disease to make sure we don't miss anything important or potentially life-threatening. Vomiting can be caused by any number of gastrointestinal problems, from the viral gastroenteritis we mentioned to a surgical problem like a blockage of the intestine, disease of any abdominal organ, so pancreatitis, hepatitis, that's liver disease, gastritis, that's inflammation of the stomach, all cause vomiting. There are many important infections, too, from meningitis to pneumonia, or sometimes a urinary tract infection. Toxins are another important category, potentially causing vomiting, including many medications that we prescribe, or alcohol, or really almost any intentional or unintentional ingestion. There's also pregnancy. Never forget pregnancy as a possible cause of symptoms in a 20-year-old woman. Rarely, disease in the brain, like a tumor or a migraine headache, can present with vomiting, and vomiting can also be one symptom of a heart attack. So how do you narrow down that long differential? A very important first step is to look for clues in the history, the story of how the symptoms unfolded. There's been no diarrhea, which makes gastroenteritis less likely. There's been no abdominal pain, so we can probably cross out an obstruction and appendicitis and gallbladder disease. In fact, the lack of abdominal pain makes me think we need to look for a cause outside of the abdomen entirely, or at least to think about those possibilities. I mentioned a brain tumor. That's a very important diagnosis, not to miss. Nicole says there have been no headaches, and this vomiting just started an hour ago. So that's less likely. But imagine if we were seeing a young woman with 3 weeks of worsening daily headaches who just started vomiting. That would be a story that suggests a possible brain tumor. She denies chest pain or shortness of breath, and she's pretty young for a heart attack. When we ask about her sexual and menstrual history, Nicole insists that pregnancy is absolutely not a possibility, though I think it's fair to still keep that in mind. What about a potential ingestion, a toxin, or a medication? She says she's been taking the Zoloft for a few weeks, and it doesn't do anything anyway. We're working on narrowing down the differential diagnosis of vomiting, so far relying on Nicole's history, the things she's telling us. The physical exam can offer clues, too. Her vital signs have remained normal during her whole ED visit. That's reassuring, though a little voice, a warning beep, goes off that something here doesn't fit. Remember, Nicole was thought to be kind of out of it when she came in, and that was ascribed to dehydration. Dehydration can cause lethargy if the brain isn't receiving enough blood flow with oxygen, but if that had been the case, we'd expect some abnormal vital signs, typically a fast heart rate or maybe even a low blood pressure. Why was she sleepy with normal vital signs? And something else you've picked up on the physical exam, not with your stethoscope or a pen light, just something you've noticed about Nicole. The way she's interacting is just kind of flat and disinterested. She mostly answers in a word or two, and she looks away, and she doesn't really seem upset or bothered. She just seems, well, blunted and what we might call flat. She's in the ED with an IV in her arm, and she doesn't seem to really care. Let's think again about those clues. After we go check in with Simon, they've moved him out of the trauma room into a regular ED area, a more private room, and his vitals are normal. He looks good. He sits up and says, "They say it wasn't a heart attack, Doc." "Yup," you answer, and you introduce yourself for real this time, figuring he might not even remember you from before. You say you're glad he's feeling better and that you'll double check on those lab tests. You'd also like to repeat the EKG again, just to be sure. "No problem," he says. Remember Simon's story. He came in with chest pain and shortness of breath and numbness, and he thought he was having a heart attack. Think fast. The team got him set up to evaluate for chest pain. Our working diagnosis now is that it was a panic attack with hyperventilation. That was your think again. The initial EKG was normal, with no evidence of heart muscle damage from a heart attack. But that doesn't 100% rule out heart muscle ischemia. Depending on the circumstances, if a heart attack is suspected, you need to repeat the EKG and the blood tests to be sure. And actually, even then, even with all the tests negative, you actually haven't 100% ruled out a heart attack. So even though your think again says this fits better as a panic attack, you still don't want to have missed an MI. Well, watch Simon longer and repeat his EKG and think again. Okay, remember sign out. We had a third patient, an elderly man brought in from a nursing home who is said to have become less responsive. You step into his room. There's an older man. He's staring off. He doesn't respond at all when you come in. A quick glance at his chart. His vitals are okay. He had a low temperature before, but is now warmed up. You introduce yourself, and he looks towards you, but his eyes look empty. You step back outside to talk with the person who brought him in. This is Mr. Douglas. He is 90 years old. By the way, throughout this course, I'm usually using first names only to keep things clear and simple. For most ED encounters, it's probably better to call adults by their last names until invited to do otherwise. For this older patient, I think calling him Mr. is more appropriate. You learn that Mr. Douglas has Alzheimer's disease and has been living in a memory care facility for 3 years. He no longer walks around on his own and lately has stopped feeding himself. He will eat some if hand-fed. Today, the staff had trouble getting him up and out of bed at all. He just wouldn't get up, so the family asked for him to be brought to the hospital. They're supposed to be here soon. Dementia refers to a chronic, persistent, gradual decline in mental processes. It usually affects memory, personality, and reasoning, and it is mostly, but not always, a disease of elderly people. It becomes more and more frequent as people age. The most common cause of dementia in elderly people is Alzheimer's disease, and we already have that diagnosis here with Mr. Douglas. But is that all to the story? Dementia does explain his faraway look and his lack of responsiveness. But the staff at the nursing home, who know him well, they say that he's having a bad day. Typically, he gets up with help and walks around, but not today. What kinds of things would cause a decline like this? Anything, really. In a patient like Mr. Douglas, with advanced dementia who doesn't talk and doesn't feed himself, almost anything can cause a decline. It could be an infection, like pneumonia or a urinary tract infection. It could be related to his nutrition or intake, perhaps dehydration or hypoglycemia. It could be bleeding in the brain, perhaps in this case related to a fall. It could be a reaction to a medication. It could even be something like a bleeding ulcer or, yes, again, a myocardial infarction. The Think Fast says there are a lot of things this could be. The Think Again, in this case, is a tricky one. What are you going to do about it? There are a lot of tests that could be done here. In a nonverbal patient, we're not going to get a lot of clues, so a thorough workup is going to be a big, broad adventure. But with Mr. Douglas, we need more information from the family now to help us know how to proceed. But they're not here yet. There doesn't seem to be any immediate life threats, so you order some basic labs and an EKG, and you hope they'll show up soon. Okay, let's head back to Nicole. You've been thinking about her in the back of your mind. She had vomiting. It's not clear why. She had also been prescribed an antidepressant, and she just seemed so flat and kind of, blah when you spoke with her. The pill bottle was empty when she showed it to the nurse. You've had an idea, and it's time to check it out. Nicole, you ask her, why were you vomiting? I had to, she says. You had to vomit, you ask? No, she says. I had to make myself vomit. I took a bunch of pills. Why did you do that, you say? I guess I wanted to die, but I changed my mind, Nicole says. So I made myself vomit, and I called Andrea, and I told her to bring me here. And I didn't tell her about the pills. What pills did you take, you ask? Just those, the Zoloft. It was stupid. Did you take any other pills? Anything else at all? She shakes her head. No. Nicole's vomiting was actually the symptom of a suicide attempt. The Think Fast to treat the vomiting and to give her fluids wasn't a bad idea, and that did help Nicole feel better. But it's a good thing that our thinking didn't stop when the vomiting stopped. The Think Again, that was important. We talked with Nicole a little while longer. There were only 4 pills left in the bottle. That's all she took. She's never done anything like this before, and she regrets doing it. She has family nearby, and she agrees to call them. We need to know these things to make sure she is safe. You glance again at her labs. They're all normal, and that's reassuring. Though Nicole was said to have been sleepy at presentation, she seems awake now, and she's becoming more talkative. Nicole denied taking any other pills, but you'll check a drug toxicology screen to make sure there are no other substances involved that might require different treatment. Some OTC medications like acetaminophen, aspirin, and iron supplements can be very toxic, and you need to make sure she didn't ingest something else. Nicole, you say, I'm glad you told me what happened, and you changed your mind about killing yourself. I'm going to make sure you're all right. We need to watch you here longer and run some tests, okay? Nicole agrees. Her tox screen is pending, and we're told Mr. Douglas's family is here. Let's head over to speak with them. There are 2 adult children, a brother and a sister who look to be in their 50s, and the brother's wife. You learn that they're now the only local family. There's another brother. He lives out of state, but they've been in touch. You explain that their father seems stable, but that sometimes even mild infections can cause a step backwards like this. What can you do for him, they ask. This is a tough question. Tough, especially in the emergency department. This isn't the best place to have those big picture discussions. But you're here, you're the doctor, and you have to try to do what's best for your patient, who, in this case, cannot tell you what he would have wanted. The best that anyone can do is to help him back to baseline. Get your father back to the way he had been a few days ago. I don't think it's possible now for him to regain much more. That's the best we can do. It's the sister who speaks up. He doesn't really even know us anymore. He doesn't talk. It's not even like it's him. You ask, what sorts of plans have you made? It turns out at the nursing home that they had completed paperwork declaring Mr. Douglas as DNR, shorthand for do not resuscitate. If he were found in cardiopulmonary arrest, no attempt would be made to revive him. But you explain there are more things to think about now. We want to make sure Mr. Douglas is kept comfortable, that's certain, but the family needs to think about what other care should be offered. Did he ever complete a living will or other documents stating what kinds of wishes he had for end-of-life care? No, it turns out he hadn't. And in that case, his children will have to decide because they know him best. We're not ready to give up on him, says the brother. This isn't giving up, you say. This is about providing the best care, what your father would have wanted. There are lots of tests and things we could do, but we need to ask, would that be the best thing for him? For now, you let his family know that Mr. Douglas is stable, that preliminary labs and the EKG haven't shown any abnormalities, but that it's possible with his low body temperature that he's fighting off an infection somewhere. To get a better idea, you'd need more tests. For now, you suggest, you'd like the family to think about this for a few minutes, and you'll make sure your nurse is available to answer other questions or come get you if you're needed. A quick point. We think of fever, a raised body temperature, as a sign of infection, but especially in elderly people, infections can be accompanied by a low temperature, or sometimes by no change in body temperature at all. You just have to be careful with elderly patients. Their bodies may not respond to stress the way we expect them to. Let's go finish up with Simon. The repeat EKG was normal, as were all of the blood tests. He says he feels better now and would like to go home. He says he's had this chest pain before, and they've been diagnosed as panic attacks. He had denied that earlier, but it sometimes helps to ask a second time. Are you in therapy, you ask? Are you seeing a psychiatrist? Oh no, he says, this doesn't happen much, and it's okay now. You let Simon know that panic attacks can be prevented and treated with therapy. Either working with a therapist or a psychiatrist can help. Sometimes medicines. You start to explain, but Simon doesn't want to talk about any of that. He just wants to leave. You tell him, look, maybe just talk to your own doctor. You don't need to end up in the ED again with this. No, Simon says he's sure he's fine now, and really, he is fine. There is no reason to keep him. So you sign his discharge orders, and you include that you've instructed him to follow up with his doctor in a few days. Will he do that? Who knows? But that's your advice. Okay, Simon's done. Out the door. How about Mr. Douglas? His family, after talking with your nurse, has decided to return with him back to his nursing home. They had talked about enrolling their father in hospice and agree that now's the time. And your nurse has already spoken with the director at the nursing home, who will have a hospice worker meet their family in the morning, which it almost is now. The sun is about to rise, and your shift is drawing to a close. You shake hands with the family, and you stop in to say goodbye to Mr. Douglas. He doesn't seem to recognize you, but you never know. Goodbye, Mr. Douglas, you say. I hope you feel better soon. Okay, Nicole, you've monitored her overnight after the pill ingestion. The blood toxicology screen showed no surprises, and medically speaking, she's in no immediate danger from the suicide attempt. But you still need to make sure she is safe. Someone who just tried to kill herself can't just be sent out of the ED. You need to make sure she is no longer in danger. How do you know she won't try again? There is no 100% guide, but we already know there are a few factors that weigh in her favor. She tried to stop the suicide herself. She made herself vomit and called her roommate to take her to the hospital. She has family nearby, she said, and she was okay with calling them. Nicole also has a psychiatrist already, and you'll be sure to call him to let him know what happened. When you get him on the phone, the two of you review these details to make sure that Nicole's risk is low for a repeated attempt. He speaks directly with Nicole too, and she'll see him in his office tomorrow. Her family's on the way to pick her up now, and you feel good about the plan and hopeful for Nicole. Once she opened up and started talking, you could see some spark was there. One shift done. The sun is up. A young man named Simon thought he was having a heart attack, but wasn't. Nicole tried to take her own life, but regretted it. You also met Mr. Douglas, and you know he won't be seeing your ED again. You thought fast about heart attacks, vomiting, and an old man who couldn't walk. Then you thought about panic attacks, suicide, and a peaceful end to a long life. Next up, another ED shift and another set of patients who might not be what they seem. Stay on your toes. In the ED, a certain amount of healthy paranoia might just keep you out of trouble and your patients alive.
Lecture 4. The story is the diagnosis.
Welcome back to our fourth lecture together on the topic of emergency medicine. We've jumped right in with patients in the emergency department, and by now, you're starting to get a feel for what this course is all about. You're going to encounter a lot of patients and a wide variety of symptoms and diseases. Along the way, you're going to get a good appreciation for how the body works when people are healthy and when people are sick or injured. More importantly, by the end of this series, you'll have a much better understanding of how emergency medicine physicians think, how we figure out what's wrong with a patient, how we use our skills to rule in or rule out certain diagnoses, and how we work with patients to improve health and treat disease. Learning how doctors think will help you communicate with your own physicians, and it will make you a better and a healthier patient. I'm also hoping you'll learn how to handle medical emergencies on your own, not for you necessarily to replace a physician, but how to think about things the way an emergency physician would. Think in terms of triage. Who needs to be evaluated in an ED right away? What are the initial first aid steps you ought to take as a family member or just a bystander or as someone who has to take care of themselves? ED docs are fast thinkers, confident and cool under pressure. By the end of this course, when faced with a medical emergency, you should feel a little more confident too. Okay, to work. As usual, we'll start our shift with a sign out from the departing ED doc. 2 patients are waiting in the back already. The physician ending his shift says one is a 40-year-old woman with abdominal pain. The other is a teenager with a hurt foot who seems fine. The physician ending his shift seems especially eager to head out because it's New Year's Eve. No problem, you say. Have a good time. Let's grab some coffee and head back to see the first patient. I think we'll all agree the abdominal pain probably comes ahead of the hurt foot. We introduce ourselves to Claire. She's 40 years old. She looks comfortable now, but says her belly has been hurting badly, on and off, for a few weeks. An initial assessment had already been done by the prior EM physician who had ordered some labs, IV fluids, and pain medications. As always, we like to start by hearing the story ourselves. You're going to hear about stories again and again in the ED. The story, the history of what's been going on, is the key to just about every diagnosis. You might think diagnoses are made from blood tests or ultrasounds or x-rays, and those are important. But as you'll learn, most of what we really need to know comes not from the lab, but from the patient's own words. That's the story, and the story is the diagnosis. Now, Claire's story. She had been in good health until maybe a month ago. She's a school teacher, married, 3 kids, all school-aged. Already, you know she's a busy person with no time to be sick. She says she's been having bouts of belly pain on and off for maybe 4 weeks. At times, it's so bad she's had to leave the classroom or stay home, but it usually gets better in just a few hours. This time, the pain wasn't going away, so her husband brought her into the ED. He'll be back soon. He went to drop off their kids with a neighbor. Now, the story is the diagnosis, but this is the emergency department. We need a concise, focused story about the symptom we're concerned about. More of a short story than a novel, just the crucial elements. In this case, it's a story about pain, belly pain to be exact. Let me tell you a great mnemonic device, a memory aid, to help a busy ED doc or medical student remember to ask the questions that need to be asked when evaluating a patient with pain. This mnemonic works for any kind of pain, chest pain, abdominal pain, headaches, anything. In fact, the same mnemonic works well for other symptoms too. The mnemonic is the phrase, old car. The word car here has 3 A's because ED docs aren't big on spelling. If you remember to ask those old car questions, you'll usually know the cause of a symptom just from the story. Old car, those letters, stand for 8 key features of a pain story, the questions we need to ask. O is onset. When did it start? L stands for location. Where does it hurt? D, that's duration. When it hurts, how long does it last? So that's the old part. Car, with 3 A's, those letters stand for C, character. What does it feel like? A, the first A is for aggravators. What makes the pain worse? The second A is for alleviators. What makes the pain better? The third A is activity. What were you doing when the pain started? And the last letter is R for radiation. Where does the pain go? That is, if it starts here, say, in the back, does it point or move or go anywhere else? Those questions, the old car questions, they make a story that will usually point you in the right direction. You might then need some blood tests or other things to confirm your suspicions. But if you don't already have a good idea of what's going on after the old car pain questions, you probably need to ask more questions to find out more of the story. Let's see what Claire says about her old car. Onset. This began about 4 weeks ago. This is not a single acute pain. It's a recurring pain that comes and goes. So we already know it's unlikely to be appendicitis or an ovarian cyst or trauma because those don't cause recurrent pain. L, location. Claire pats over her right upper abdomen. That's not where typical kidney stone pain might be. That would be in the flank or the back. It's also not where the pain of a gastric ulcer typically would be, which is more in the upper middle of the abdomen. And that's also not where people typically feel the pain of reflux either. That location, the right upper abdomen, is where the liver and gallbladder are located. Duration. Claire says the pain lasts a few hours, sometimes maybe 4 or so, not usually longer than that, but always more than a few minutes. C, character. It just hurts, she says, not burning like an ulcer might be. It's sharp and starts suddenly and kind of ends suddenly too. A, aggravators. The pain often begins, Claire says, when she eats. Eating makes it worse. That's another clue. Alleviators, the second A. It just gets better after a while, she says. She tried an antacid. That didn't help. That's another clue against ulcers or reflux. The third A is activity. What's she doing when the pain starts? Usually eating, she says, or maybe just after eating. That's when the pain starts. And the final letter, R, radiation. The pain often sort of shoots up to her right shoulder from her right upper abdomen, up towards the shoulder. But not always. Now, there's a story. Not all of the clues are exactly consistent, and not every answer was really needed. You never know what clues you need, so collect as many as you can. And always keep in mind that patients do not read medical textbooks or listen to medical lectures, at least not most patients, and not every symptom occurs exactly as classically described. Still, that overall story, it should hang together and narrow things down. What do you think about Claire? The pain is upper right. It's not near the pelvis, so that makes anything gynecological unlikely. It's also unlikely to be a stomach sort of pain because it's off to the right side. The pain itself is right over the liver and gallbladder. And gallbladder pain, the pain that sometimes comes with gallstones, classically gets worse after or during a meal, especially a rich or a fatty meal. You ask Claire, what kind of food really makes it worse? I don't know, she says. I guess dinner. What were you eating tonight, you ask, when you came in? Remember, today she came in because the pain was worse and lasted longer than usual. Claire says it was a big holiday meal with her sister's special prime rib roast. That's a huge and probably very fatty meal. Claire's feeling comfortable now. She had been given pain medicines. You tell her you're going to check some labs, but that you think it's her gallbladder. She says, yeah, that's what my mom said. She had hers out when she was 42. You'll swing back in a little while to talk more, figuring by then her husband will be back and you'll only have to explain things once. Meanwhile, you look at the board. The teenager's still back there somewhere with her hurt foot. She's got a green dot next to her name, meaning she's not a triage priority, but you figure you ought to go by and at least check out the story. Meanwhile, another patient has been brought back, a 55-year-old man with a chief complaint written on the intake sheet of acting sleepy. We haven't used that term before, chief complaint. It's an important term for ED care and really for any medical interaction. The chief complaint is a phrase, usually expressed in the patient's own words, of the main thing they're worried about. It's the answer to the question, why did you come into the ED tonight? Claire's was, my belly hurts. The chief complaint doesn't always end up being the main problem that the doctor worries about. Sometimes the chief complaint might be a hurt elbow in a person discovered to have diabetes, but the chief complaint should always drive the encounter and should always be at least the starting focus of the evaluation. And by the end of the encounter, the chief complaint should always be addressed. Even if a different diagnosis was made, you have to go, eventually, back to the chief complaint to make sure that whatever the patient was worried about, that concern was addressed. Some people prefer to call the chief complaint a chief concern, abbreviated the same way, CC, so we don't have to replace our pre-printed forms. Whichever phrase you use, the chief complaint is a starting point for the diagnostic journey. It's not necessarily where you end up. Now, this new patient with the chief complaint acting sleepy, what does that make you think about? It could be alcohol intoxication. It's New Year's Eve. Or it could be from some kind of head trauma. Or maybe from poor oxygen delivery to the brain. Or maybe he's just not sleeping well at night because his spouse snores. In other words, from the chief complaint, this could be pretty much nothing in terms of a life threat, or it could be a very, very big deal. I think Mr. Sleepy just jumped ahead of Ms. Hurt Foot. This is the ED, and someone is going to be waiting a bit longer. We step into a new room. There's our patient in a gown. He's asleep and looks comfortable. He's hooked up to a cardiac monitor, and all of his vital signs look normal. He's just asleep. With him is his wife, who does not look happy. What is wrong with him, she asks. All he does is sleep now. Introductions are done. You wake up Juan, that's his name, and he says, "I don't know why, I just can't stay awake." Juan isn't slurring his words, and he woke up easily when you shook him a little. Here's Juan's story. And this time, I'm going to summarize a bit here rather than run through all of those old car questions one by one. Juan had been in overall good health, though he has had epilepsy since he was a child. That's a condition that causes recurrent seizures. Juan sees a neurologist and takes medicine to prevent his seizures. He actually hasn't had one in several years. The medicine he takes has been working well. Juan has been sleeping well, he says. Too much, says his wife, and there's been no pain and no shortness of breath. There's been no fevers, really no other symptoms. From the old car questions, you learn that this has been going on for 3 weeks, that he's pretty much sleepy throughout the day at any time, and he's tried drinking more coffee, but hasn't noticed that that has helped. No other clues here, really. A bit of a head scratcher so far. But low oxygen to the brain can make you sleepy, as can a lot of drug ingestions, of course. Juan denies that, but still, there are drugs of abuse, especially pain medications, that have become a much more common problem. You'd also like to make sure that Juan's blood sugar is okay and that he's not anemic and doesn't have thyroid disease. So you order some labs. They'll be back in an hour or so. Let's go meet our teenager and her foot. We head down the hall. There's a flashing light on the board. Claire's labs are back, but you figure she's comfortable and can wait a bit. You'd like to at least see the foot first. It's funny. That's how doctors think. Before you meet the patient, before you have a face and a name, you think about a person as a symptom. The hurt foot, or Ms. Belly Pain, or Mr. Sleepy. It's a mental shorthand we all use. But please, let's not forget to use real names and be respectful when we meet people. People are not diseases or symptoms. There is really no Mr. Sleepy. But there is a teenager, or a preteen, it turns out. Jennifer is 11. She's at that tall and gangly age, and she looks a little bored. She's here with her mom, who says she's been complaining more and more of her left foot every day now. Let's see what the old car questions say. Onset was a week ago, Mom says, but Jennifer says it's only been 6 days. The location is the outer edge of her left foot. It hurts all the time now. The character is just hurty, that's Jennifer's word, and it's alleviated by staying off her feet and playing her new Xbox video game she got for Christmas. The pain doesn't radiate anywhere. What were you doing when it started? You ask. You want to know, was it a sudden pain, maybe from trauma, or did it just kind of creep up over a few days? Jennifer says she doesn't remember exactly when it started, so that means it's less likely to be trauma, or at least not one single significant injury that led to this pain. You've got an idea, a little inspiration. You ask, since this is New Year's Eve, what else did you get for Christmas, Jennifer? Now it's Mom who rolls her eyes. Too much, Mom says. Jennifer says sweaters and 2 dresses and books and a new hockey stick. Yes, a hockey stick. It turns out Jennifer is an ice hockey player, though it's vacation now and there's no practices and she hasn't even had a chance to use it. And a new Xbox and a pair of Heelys. And wait, you say, what's a Heely? Jennifer looks at you like you're an idiot, which is a special skill that teenagers have. What's a Heely? What kind of a question is that? It's a cool kind of new shoe that has a built-in roller skate. So you can kind of stand or walk or roller skate, and you can wear them anywhere and just roll along whenever you want to. She's wearing them now, she says, and she shows you by rolling along the floor with one leg bent and the other leg kind of held in front for balance. You have to jump out of the way so you don't get run over. By the way, the cases we're using in this course are all fictionalized. They're usually composites of real cases mixed up with details added or changed to protect patient privacy. This case, I really only changed the name. This was my patient a few Christmases ago at the height of the craze of these Heely shoes. And that's what the problem was. Jennifer got Heelys for Christmas and had been using them every day, pretty much wearing them all the time, and rolling along in this kind of awkward stance. Rolling around her house and the driveway and the mall and now the ED. She pulls off the Heelys for you, and you can even see the edge of the foot where it's being pinched in the shoe. That's exactly where the pain is. Jennifer, you say, I think you need to lay off the Heelys some. Just limit them to an hour or so a day, and I think you'll be fine. Yay, says Jennifer. Can I go home now? Her mom gets up to leave and says, Happy New Year. You tell them to wait just a minute. The nurse will be back with discharge instructions. She can also take some ibuprofen or ice her foot if it really hurts. And if it keeps hurting, they ought to go see their pediatrician, who might order an x-ray. But really, you think that's not necessary now. Jennifer and her mom are fine with that, and you head back to see how Claire is doing. She remains comfortable and well, and her husband is there, along with one of her kids, who was feeling a little clingy and didn't want to stay at the New Year's party without her dad. She looks to be maybe 8, and you wonder if she'd like a pair of Heelys too. Anyway, you introduce yourself, and the husband says thanks. He appreciates it that his wife was really uncomfortable. You've reviewed the labs, which are normal, except for some of what are commonly called LFTs, which is a common abbreviation for a set of blood tests commonly called liver function tests. It's an unfortunate abbreviation because it's wrong, and that sometimes makes explaining things difficult. Worse, that incorrect name, LFTs, sometimes misleads doctors and clinicians. These are very common tests, usually included in ordinary chemistry panels done on patients every day. What's being measured are enzymes, chemicals released from cells. Those cells are mostly, but not only, found in the liver. That's one reason the name LFTs is wrong. You can have abnormal LFTs from diseases of the muscle or salivary glands, or from problems with the blood that have nothing to do with the liver. The tests also don't actually test function at all. Someone with a perfectly functioning liver may have very abnormal liver function tests. And conversely, someone whose liver is functioning poorly might have nearly normal LFTs. So, bad name, but they're still useful tests. In Claire's case, given the suspicion from the story of gallbladder disease, these elevated or abnormal LFTs help confirm that diagnosis. She doesn't actually have liver disease, or at least not significant liver problems. The LFTs are elevated because Claire probably has gallstones. You explain all of this to Claire and her husband after suggesting that Dad lend his daughter his phone to distract her. The gallbladder is a little sac tucked under the liver that stores and collects bile from the liver and pancreas. Those are digestive juices, enzymes, and other chemicals released especially after meals by the gallbladder squeezing its contents through a little duct into the small intestine. Gallstones are little stones of solidified material, mostly made of cholesterol. These sometimes run in families and are most commonly found in women, often in their 40s. They're more common in people who are overweight. Gallstones themselves don't necessarily cause symptoms. About 80% of the time, there are no symptoms at all. Symptoms occur when a stone blocks the cystic duct, the small tube that empties fluid from the gallbladder into the gut. After a meal, the gallbladder contracts, and that's when the pain happens. The flow of bile is blocked by the stone, and that hurts. It's usually in the right upper part of the abdomen over the gallbladder. Happens especially during or after a fatty meal and typically lasts less than 4 to 6 hours, probably until the gallbladder relaxes and stops trying to squeeze. This fits Claire's story well. The location, the onset, the association with meals, it's all there. Of people with gallstones and no symptoms, probably 15 to 30% will develop this kind of pain called biliary colic within 15 years. Claire is now feeling better, so you're not worried about a possible complication of gallstones called cholecystitis. This is when bacterial overgrowth occurs, leading to persistent inflammation of the gallbladder. There's even more persistent pain, often along with fever and chills. Patients with cholecystitis will typically be admitted for fluids, pain control, and IV antibiotics and given nothing more to eat until a surgeon is consulted. For Claire, we can send her home with pain medication, setting up an outpatient ultrasound to confirm gallstones. She can follow up with her own doctor and will probably be referred to a surgeon for an outpatient evaluation to schedule a cholecystectomy or removal of her gallbladder. You warn her to stay away from the fatty meals, and you send Claire and her family home. Let's head back to Juan, who has predictably fallen back asleep. His wife is there too, talking on her phone. All of his labs are normal. He's not anemic. His thyroid is fine. We tested for drugs of abuse like opiate pain medicines, and everything is negative. Yet, here he is, asleep again. The story is the diagnosis. We don't have a diagnosis yet, which usually means we need more story. You ask again, Juan's been sleepy for 3 weeks. Nothing else has changed. He takes medicines for epilepsy and asthma, but those have been used for a long time, and doses haven't changed, and they've never made him sleepy before. There are no other medicines. He's sleeping well. You ask a few questions about his work and home life, fishing around to see if maybe there's depression. That can certainly cause excessive sleeping, but while he's awake, Juan seems animated and bright, and not in any way depressed. You figure maybe it is related to the epilepsy. Seizures can cause sleepiness. It's called a postictal phase, a period of sleepiness after a seizure, and seizure medicines themselves can be sedating. You decide to call Juan's neurologist and ask first to clarify his doses. I take 3 of the blue pills twice a day, morning and night, like always, he says. His wife stares at him. That was the old pills, remember? The pharmacy was out of that strength. You're on the new ones now. You're supposed to take just one of them. It turns out that, yes, 3 weeks ago, when Juan refilled his medication, the pharmacy was out of the usual generic form at his usual strength. So they substituted a higher strength medicine and told him to only take one of them instead of 3 of them twice a day. His wife says, "You were there. They told you." "Yeah," says Juan. "Yeah, they told me. I guess that's why the bottle is half empty now. It was supposed to be a 3-month supply, but he's used up 3 times as much already." He says he was starting to wonder about that. You speak with Juan's neurologist, who assures you that even at this triple dose, it's unlikely that there will be any long-term effects. You've already checked some blood tests, including those LFTs on Juan, and there's no evidence for liver damage or any problem from the excessive medication. You pass along to Juan instructions from the neurologist to skip the next 2 doses and then resume 1 pill twice a day. Some lessons here. It's crucial that patients understand medication instructions. Repeat them back, write them down, do whatever you need to do when you're prescribing to make sure that medications are taken as directed. And Juan, when he noticed that the pill bottle was already half empty, that was the time to speak up, to ask his pharmacist or doctor. It would have saved him a New Year's Eve trip to the ED. As you head out of Juan's room, your next patient has arrived by ambulance, a child having trouble breathing with widespread hives. They're bringing him back now. His name is Sam. He's 3 years old, and he's known to be peanut allergic. He suddenly developed hives and trouble breathing at a New Year's party. He was thought not to have eaten any peanuts, but especially at a crowded party, you never know what a child could have gotten into. The story is the diagnosis, and the story so far is short, but it's enough to tell you what needs to be done. ABCs first. Sam is breathing on his own, and his circulation is okay, though his blood pressure is low, and his heart rate is fast. He's covered with hives, warm, raised pink areas on his skin. He's on extra oxygen from the ambulance, and that's continued. And you have the tech immediately administer an injection of epinephrine for what's called an anaphylactic reaction. Within minutes, the hives start to fade, and Sam's breathing improves. Sam will need further evaluation. But in this case, the definitive treatment, the epinephrine, has already been given, just based on a scrap of a story. Sometimes you don't have time for all of those old cars questions, and you have to think fast and act fast when a life is in danger. The story can come later, and that's when you learn that indeed someone had brought peanut cookies to the party, which were put up on a shelf away from the guests until another guest found them and put them back down for everyone to enjoy. We're going to need to watch Sam more, especially to follow his vitals and blood pressure. He may still need extra fluids and oxygen, or further doses of epinephrine or other medicines to control the allergic reaction. And most importantly, you know you'll be reiterating the instructions for the parents, making sure they know to give that epinephrine themselves through an automatic injector if anything like this happens again. Give epi first, then call the ambulance. The story is the diagnosis. The story the patient and the family tells you, and the answers to the questions you ask them. But, as you'll see next time, sometimes a story doesn't quite fit. That's a time to be especially careful. See you then.
Lecture 5. Hidden Clues in the Emergency Department.
Welcome back. As we learned last time, the story is the diagnosis. Most of what doctors need to know is what's called the history of the present illness. That's kind of an awkward phrase, but it refers to the story about what's going on now. Not the past history, not what happened before, but the present illness. It's the story that answers the question, why did you come to the emergency department today? Well, we know why we came. It's our job, and we're here for our next shift. Let's see what our patients have to say and what their stories can tell us. As you're going to see, even when a story isn't the right story or the truthful story, it still contains the clues we need to figure out a diagnosis. Our first case today is Maria. She's 48 years old, and she is not happy. She was here in this very ED yesterday. We saw her ourselves, and now she's back and not feeling better. You know, one thing about ED docs, we really don't develop long-term relationships with patients, at least not with most of them. Sure, there are some so-called frequent flyers and some medically complex patients that return again and again to the same ED, but most of our patients we meet once and we never see again. In this case, Maria would have been happier if she didn't have to come back. Maria's first visit yesterday was, we thought, fairly routine. Her chief complaint yesterday was, I have a bladder infection. The story, or the history of present illness, was that she had one day of increasing pain on the side of her belly, kind of the flank area on the right, along with frequent urination. The recorded vital signs and physical exam were normal. It was noted that Maria looked comfortable and well, and that she had had no fever. Her urine tests showed first that she was not pregnant, and second that her urine contained white blood cells. She was sent home with a prescription for an antibiotic to cover a presumed urinary tract infection and told to follow up with her own doctor or return to the ED if symptoms didn't improve soon. A fairly routine encounter, though in retrospect now, you're wondering if something was missed. Let me step back for a moment, just a few words so we're all on the same page about those urine tests. We do a lot of different tests in the ED, and in this course, I'm not going to spend a lot of time explaining all of them in detail. But a basic knowledge of the most common tests, the kind of tests that are done every day, can help you understand medical encounters better. Lab tests are not miracles. They're not perfect, and every one of them has limitations. Doctors and patients are headed for trouble if they focus too much on lab results and miss the big picture. The basic urine test is called a urinalysis, or sometimes a urine dipstick. It's simple and quick and inexpensive. A plastic strip with little pads is dipped into urine, and those pads change color to detect different chemicals or other elements in the urine. One pad tests for glucose or sugar. That would be positive in a person with poorly controlled diabetes or anyone whose blood sugar was running high for any reason. There's another little pad that changes color if there are red cells in the urine, and another one for chemicals called nitrates that is often positive when there's a urine infection. In Maria's case, only one pad lit up, showing white blood cells in the urine. White blood cells are part of the immune system, the part that fights infection. And sure enough, white blood cells in the urine usually means infection in the urine, but not always. The best way to know if there's a urinary tract infection is a different urine test called a urine culture. It's a very simple test. A portion of urine is incubated and kept warm for a few days and then examined for the growth of bacteria. If there's a lot of bacteria there, there's an infection. It's a reliable and accurate test, but it takes a few days. So someone with urinary symptoms and an abnormal urine dipstick is presumed to have a urinary tract infection and often starts therapy before the urine culture comes back. We wouldn't make someone wait 2 days if they're uncomfortable, and starting antibiotics now can help prevent complications from the spread of infection. But we don't really know for sure if it's an infection until that culture comes back. We check the computer, and Maria's urine culture from yesterday is still pending. We just don't know yet. One other test was done on Maria's urine, a test for a protein called beta-HCG that's produced in very high amounts during pregnancy. It was negative, meaning Maria is not pregnant. That's a very important test to do in any woman with pelvic or abdominal symptoms. She came in with the pain in her side, remember, and that could have been an ectopic pregnancy. That is a big deal and a diagnosis never to miss. Okay, this is what we know already. Maria had pain in her side and frequent urination. Her urine had white blood cells in it, and she's not pregnant. She started antibiotics yesterday, or at least we prescribed antibiotics yesterday. Maybe she never filled the prescription, or maybe she vomited up the medicine. We don't know yet. But she's back in our ED, so something, as we say, something ain't right. Her chief complaint today is, my side hurts. You see her vital signs. She has a fever now of 100.9, and her heart rate is a little fast at 98. As you step into the room, she says, "Doctor, this hurts. I think I have a kidney stone." And she points to the side of her abdomen on the right flank. A quick aside here, a quick observation. Maria yesterday said, "I have a bladder infection," and today says, "I think I have a kidney stone." I don't know if Maria is a doctor or a nurse, but she seems to like to make her own diagnoses. Sometimes patients are right. You should never ignore what patients think is wrong with them. But on the other hand, sometimes patients are wrong. You are the one responsible for getting it right. So let's not let Maria's guess box us in here. We don't know yet if she has a bladder infection or a kidney stone or neither one of these things. We'll keep an open mind and find out more of the story. Maria says she started taking the antibiotics yesterday, and she doesn't really notice that she's urinating frequently anymore. The pain is pretty much constant now on the right and is worse than yesterday. She's never had painful urination and says there's been no vomiting and no diarrhea. On to our physical exam. Maria is holding very still. She looks uncomfortable, and she doesn't seem to want you to touch her at all. Her pulse, her heart rate, has risen to 110 beats per minute. Her other vital signs are normal. She will sit up for the exam, though moving makes her wince and gasp a little. What's most noticeable on her exam is that her belly is tender to touch. When you gently press, she winces and moves her hand like she's pushing you away. She's tender all over her belly, but especially so on the right side. So what do you think? Is this a urinary tract infection? Probably not. It didn't improve with antibiotics, and her pain really isn't down low over her bladder, and it isn't over her kidneys in the back. It's on the right side. Also, though you can get abdominal pain with a urinary tract infection, she shouldn't be so tender to touch. She also never had the classic urinary tract symptom of painful urination. Even at the first encounter yesterday, she never said that it hurt to urinate. You're starting to question whether she ever had a bladder infection at all. What about a kidney stone, as Maria suggested today? That doesn't quite fit the story either. A stone will usually cause at least a little blood in the urine, and Maria didn't have that. But even more compelling is today's exam. She's lying very still and trying not to move. People with kidney stones, they don't act like that. They writhe around and kind of squirm and flop back and forth, trying to find a comfortable position.